Chapter 31 of the 2018 Clinical Practice Guidelines is on neuropathy. My name is Alice Chang, and I am narrating this chapter on behalf of the authors Vera Brill, Ari Briner, Bruce Perkins, and Douglas Sokodny. Key changes in this chapter include new information on diagnosis and management of diabetic autonomic neuropathy. The neuropathy checklist is as follows. First, prevent neuropathy with blood glucose control. Second, screen with monofilament or tuning fork. And third, treat painful symptoms with anticonvulsants or antidepressants. It is estimated that 40 to 50% of people with diabetes will have detectable neuropathy within 10 years. The neuropathy usually manifests in the form of sensory motor poly or mononeuropathy, and those with neuropathy are at increased risk for foot ulceration and amputation, neuropathic pain, significant morbidity, and increased usage of healthcare resources. Risk factors for developing neuropathy include elevated blood glucose, elevated triglycerides, high BMI, smoking, and hypertension. Therefore, it is important that we screen individuals for diabetic neuropathy so that we can do the preventative care necessary. There are different methods to screen for diabetic neuropathy. This is one shown here, which is rapid screening for diabetic neuropathy using the 10-gram monofilament. There are several ways to use the 10-gram monofilament to detect diabetic neuropathy. This is one of the examples which has in fact been validated. It involves showing the 10-gram monofilament to the patient, then touching it first to the patient's forehead or sternum so that the sensation is understood. Then the patient is to be instructed to say yes every time the monofilament stimulus is perceived. With the patient's eyes closed, apply the monofilament to the dorsum of the great toe proximal to the nail bed as shown in the illustration. Use a smooth motion touch the skin, bend the filament for a full second, then lift from the skin. Perform this stimulus 4 times per foot in an arrhythmic manner so the patient does not anticipate when the stimulus is to be applied. For each of the 8 stimuli, assign a score of 0 if it is not perceived, 0.5 if it is substantially less than that perceived on the forehead or sternum, and 1 if it is perceived normally. A score of 3 out of 8 correct responses means that the presence of neuropathy is likely. A score of 3.5 to 5 means that the risk of new onset neuropathy in the next 4 years is high, and a score of 5.5 or greater indicates that there is a low risk of neuropathy onset in the next 4 years. Refer to neurology if non-diabetic neuropathy is suspected. An alternative screening method for protective sensation using the 10-gram monofilament is shown here. In this case, you want to conduct the exam in a quiet and relaxed setting. Begin by applying the monofilament to the hands, elbow, or forehead so that the patient knows what to expect. Ensure that the patient cannot see whether or where the monofilament is being applied, and test the 3 sites on both feet that are shown in the figure. You want to press the monofilament against the skin enough to bend the filament for 1 second and then release. Repeat this application twice at the same site, but alternate this with at least 1 mock application in which no filament is applied. So therefore, there's a total of 3 questions per site. Protective sensation is present at each site if the patient correctly answers 2 out of 3 applications. If there are incorrect answers, the patient is then considered to have absent protective sensation and therefore at higher risk of ulceration. Another method of screening for diabetic neuropathy is use of the 128 Hz vibration tuning fork with the on-off method. So first you want to strike the tuning fork against the palm of your hand hard enough that it will vibrate for approximately 40 seconds. Apply the base of the tuning fork to the patient's forehead or sternum and ensure that the vibration sensation, not just the touch sensation, is understood. With the patient's eyes closed, apply the tuning fork to the bony prominence situated at the dorsum of the first toe, just proximal to the nail bed. Ask if the vibration sensation is perceived. Ask the patient to tell you when the vibration stimulus is stopped, and then dampen the tuning fork with your other hand. 1 point is assigned for each vibration sensation perceived, which is vibration on. Another point is assigned if the correct timing of dampening of the vibration is perceived, vibration off. Repeat this procedure again on the same foot, then twice on the other foot in an arrhythmic manner so the patient does not anticipate when the stimulus is to be applied. Though this test can be used to rule out the presence of neuropathy, unlike for the monofilament described above, threshold scores do not exist to indicate the risk of future onset of neuropathy. And again, refer to neurology if non-diabetic neuropathy is suspected. So that is how to screen for diabetic neuropathy, but what can we actually do to try to modify the situation? The only thing that we have to actually be disease modifying is glycemic control. Glycemic control is effective for both primary prevention as well as secondary intervention in type 1 diabetes. We know this from the DCCT trial, or the Diabetes Control and Complications trial, where patients were randomized to receive more intensive glycemic control or standard glycemic control, and these were individuals living with type 1 diabetes. We know from the DCCT that intensive glycemic control resulted in reductions in neuropathy no matter how you screened for the neuropathy, whether it be by neurologic examination, by autonomic nerve study, or by nerve conduction study. Therefore, glycemic control is critical to help reduce the onset of neuropathy as well as secondary prevention. For an individual who has already developed neuropathy and is complaining of neuropathic pain, many treatment options exist. First-line treatment should be anticonvulsant or antidepressant therapy. Second-line therapy may include opioids. However, opioid use should be selective after other options have failed to be effective, and clinicians must be aware of the risks of tolerance, abuse, dependency, and addiction. Other options include topical nitrate, capsaicin, and transcutaneous electrical nerve stimulation, also known as TENS. The anticonvulsant therapies that have been shown to be beneficial for neuropathic pain include gabapentin at a starting dose of 300 milligrams twice daily or bedtime, and titrating eventually up to a maximal dose of 3,600 milligrams per day. The relative costs are listed on the far right. Another option is pregabalin at 75 milligrams twice daily, and then titrating upwards to a maximal dose of 600 milligrams per day. And then finally, valproate, starting at 250 milligrams twice daily, and then titrating up to 1,500 milligrams per day being the maximum. Please note that gabapentin is not currently approved by Health Canada for the management of neuropathic pain associated with diabetic peripheral neuropathy. Another treatment option are antidepressants for neuropathic pain. Medications include amitriptyline, starting at a dose of 10 milligrams QHS, and then titrating up to a maximum of 150 milligrams a day. Another option would be duloxetine, starting at 30 milligrams a day and titrating up to 120 milligrams a day. And finally, venlafaxine, starting at 37.5 milligrams twice daily and titrating eventually up to 300 milligrams a day. Please note that amitriptyline and venlafaxine have not been currently approved by Health Canada for the management of neuropathic pain associated with diabetic peripheral neuropathy. As mentioned, opioids are second-line therapy for neuropathic pain. And although the following agents have demonstrated efficacy for neuropathic pain, their use should be selective after other options have failed to be effective, and clinicians must be aware of the risks of tolerance, abuse, dependency, and addiction. The limited use of these agents should follow the principles of the 2017 Canadian Guidelines for Opioids for chronic non-cancer pain. The opioids that have been studied in diabetic neuropathic pain include dextromethorphan, morphine SR, oxycodone ER, tapentadol ER, and tramadol. Other treatments for neuropathic pain include topical nitrate sprays, capsaicin cream, or TENS. When thinking about treatments for neuropathic pain, we need to remember that the effects are limited and very few patients will ever achieve complete relief. So therefore, 30 to 50% reduction in pain is considered to be clinically meaningful. The recommendations for this chapter are: 1. In people with type 2 diabetes, screening for peripheral neuropathy should begin at diagnosis of diabetes and occur annually thereafter. In people with type 1 diabetes, annual screening should commence after 5 years post-pubertal duration of diabetes. Recommendation 2. Screening for peripheral neuropathy should be conducted by assessing loss of sensitivity to the 10-gram monofilament or loss of sensitivity to vibration at the dorsum of the great toe. Recommendation 3. People with diabetes should be treated with intensified glycemic control to prevent the onset and progression of neuropathy. Recommendation 4. The following agents may be used alone or in combination for relief of painful peripheral neuropathy: anticonvulsants, namely pregabalin, gabapentin, or valproate; antidepressants, namely amitriptyline, duloxetine, or venlafaxine; topical nitrate spray. In people not responsive to the above agents, opioid analgesics such as tramadol, tapentadol ER, oxycodone ER may be used. Prescribers should be cautious due to the risks of abuse, dependency, and tolerance, and follow the recommendations of the 2017 Canadian Guidelines for Opioids for chronic non-cancer pain. Key messages from this chapter include: elevated blood glucose levels, elevated triglycerides, high body mass index, smoking, and hypertension are risk factors for neuropathy. Intensive glycemic control is effective for the primary prevention or secondary intervention of neuropathy in people living with type 1 diabetes. In people with type 2 diabetes, lower blood glucose levels are associated with a reduced frequency of neuropathy. Simple physical examination screening tests, such as the 10-gram monofilament on the dorsal aspect of the great toe bilaterally and vibration perception with a 128 Hz tuning fork, perform reasonably well for the identification of neuropathy and prediction of its future onset. Key messages for people living with diabetes include: exposure to high blood glucose levels over an extended period of time can cause diabetic peripheral neuropathy or damage to the nerves that go to the feet, legs, and when markedly advanced, to the hands and arms. The most common symptoms of diabetic peripheral neuropathy are loss of sensations in the toes and feet, and presence of symptoms such as sharp shooting pains, burning, tingling, a feeling of being pricked with pins, throbbing, and numbness. Diabetic peripheral neuropathy increases the risk for foot ulcers and amputation, and your healthcare provider or foot care specialist can test for diabetic peripheral neuropathy by lightly pressing a thin nylon rod, known as a 10-gram monofilament, and by using the 128 Hz tuning fork on the top surface of your big toe. Other key messages for people with diabetes include the following: Although there is no cure, there are many ways you can effectively manage diabetic peripheral neuropathy, including proper foot care, including daily foot inspection, effective blood glucose control, and medications that may help with nerve pain. In addition, diabetic autonomic neuropathies affect the part of the nervous system responsible for control of internal body functions and may target the heart, gastrointestinal tract, and genital urinary system, and can cause sexual dysfunction. For more information about the guidelines or this particular chapter, please visit guidelines.diabetes.ca or download the app from Google Play or the App Store. Thank you very much for your attention.